you find out it's a false negative. And then you find your clients are starting to faint. So you don't realize. My question is, why when you do the hypersensitivity reaction, we draw a circle here and you put intradermally a few drops to make a bleb like this and see the reaction. Why do we inject in these areas? In these areas. Why do you do the test here?
Actually, they have no hair to camouflage the...
Okay, it's thin skin, it's stretched skin, and you can easily see the reaction. Okay? Like I said, sometimes you can do this. It's negative. And then when you start injecting, it's false negative, and there is reaction. So what do you do if you want to be sure it's not going to be negative?
Usually,
Both hands, perfect. And if you want to be more sure, yes, I تبقي more sure. So, one hand is okay, two hands are better. But if you want to be perfectly sure that there is not going to be an allergic reaction from this product, where do you do the test? I'll tell you something that's easier. Do both hands, but do something with them again. Something that has thin skin, you can easily see the reaction, and it's close to large vessels. Put those drops, yes, in the neck here. Tuck here, then you can see a good reaction from it.
Doctor, sorry. I once had a patient. When she left my office, there was nothing, no reaction at all in this area.
Okay.
Okay. Then one day later, she sent us a photo to the clinic that she has this big red area, even outside of the margins that I marked. What is the cause of that? And she had no other manifestations of sensitivity, but that's what she sent to the clinic. Why did that happen?
Well, there's something called delayed reaction. You can never predict it. But on the other hand, not all patients are honest. She probably did some cosmetics. Even if you wash some dishes with Clorox, this will affect you. Okay? Maybe she has an autoimmune disease she doesn't know anything about. Something called coincidental disease? Most of the patients discover things they have just by chance. They are doing a checkup, you do something, and then it turns out that they have something else they had no idea about, right? But there's something called a delayed reaction. That's nothing, just give her some antihistaminic, some anti-inflammatory, even if small doses of corticosteroids, that's it. As long as it's not a vascular occlusion, this is the problem. Any other thing, so what? Okay, so, please.
For the lip fillers, for example, if one lady came and they have some bruise or vascular occlusion over the lips, and she said that she has consumed 1.5 ml from the other clinic. So how much, how can we calculate the amount, the units of the Hyalase that for the 1 ml? How many 0.1 ml of the hyaluronic acid with this one? What should be the ratio?
So no, it's not like this. It's per area. Per area. Your maximum is from 300 to 500 units per area every 2 hours. So even the whole right side of the face, that's 300 to 500 units. 300 to 500 units.
Okay. For the lips also, 300?
This is your maximum, from 3 to 500. You can go for 150, 200, that will be enough. Supposing it's one area on the upper lip, do I need to do 300 units here? Like this person I showed you. Just an area in the lower lip. If everything was okay and just this area, will you put 300 units here?
No.
But if he has the whole lips, I could 300, I could go up to 500 as well.
For the lips, for the filler migration towards that area also, we will put 100?
I don't put Hyalase for any filler migration. Like I said, I only use it for emergency medical conditions. I was telling you this story. I had a client of mine who came to my office. We did fillers for her cheeks and fillers for her jawline. She looked very nice. She went back home. I have a little bit of headache. What makes me comfortable is I put a hot foment on my face and I sleep. So she put that hot foment and she went to sleep. And the very next day, The very next day, she came to my clinic with complete asymmetry between both sides. This side was so flat, this side was plump. So just hot foments just dissolves the whole fillers. Try give. I don't care. Just try giving your clients who do lip fillers. Let them drink hot Nescafe, coffee, tea, and watch the fillers a few days later. It's gone. That's why I always tell them, for 3 or 4 days, keep your drinks warm, not hot. Okay, so let me show you this. Now, I've done a lot of calivaric workshops. And as you know, this is called the pupil of the eye, right?
Yes.
And this is called the iris. So the inside, this is called the medial iris. This is the lateral iris. Medial iris, lateral iris. Everything medial is inside, lateral is the outside. So if you draw a line from the medial iris, so someone is looking straight ahead, this is the medial iris, this is the medial iris. In 100% of people, not in 99, but in 100% of people, here's where the supraorbital artery will come out. And in about, I think about 83% of people, they have a notch here. It's called the supraorbital notch, and you can feel it. But in about 17% of people, it's not a notch. It's a small opening, small hole in the skull. It's called an ostium. We call it an ostium, remember? Yes. So it comes out from an ostium which you can't feel. But in 100% of people, from the medial iris, here is where the supraorbital artery will come out. Now moving about 8 millimeters to 1 centimeter. So 8 to 10 millimeters, or about 0.8 to 1 centimeters. Medially, or the most medial frown line. So you ask her to frown, see? And I'm not talking about the frown lines from the procerus muscle. I'm talking about the frown lines from the depressor and corrugatus. Depressor superciliary muscle, corrugator superciliary muscle, or superciliary muscle. So this is the most medial crease. Can you see it? About 0.8 millimeters to 1 centimeter medial to the supraorbital artery. And with that medial crease, in 100% of people, the supratrochlear artery will come out. Now the supraorbital artery and supratrochlear arteries will go up some, and they will give branches. And superficial temporal artery will have a temporal branch and a frontal branch. And the frontal branch of the superficial temporal artery will anastomose with branches from the supraorbital artery. Okay. So let's take a look at this again. So you have the supraorbital and supratrochlear arteries, and branches from here will anastomose with frontal branch of the superficial temporal artery. But then you have the facial artery here, okay, which gives off superior and inferior labial arteries. It continues as angular artery, and this angular artery gives off dorsal nasal branches and so on. So this angular artery, so it's the facial artery here, then it's the angular artery. This angular artery anastomoses with descending branches from the supratrochlear artery. So here's one area where the external and internal carotid artery systems meet. Here is the second area where external and internal carotid arteries meet. So injecting in this area, like people who do the holotemporal area, if you inject into the vessels, it can travel from the external to the internal carotid artery system, back to the ophthalmic artery, optic artery, and you get blindness. Likewise, angular artery anastomoses with descending branches or branches from the supratrochlear artery. It can pass again to the eye and cause blindness. And the most recorded cases of blindness due to filler injections were usually from fillers to the nose. And I'll show you why in just a short while. Okay, so from the most medial crease, supratrochlear artery comes out and gives off branches. And then from the medial iris, it's a little bit too far out. But I'll tell you, in 100% of people, from the medial iris, the supraorbital artery comes out and gives branches off as well. Now, the facial artery starts from the anterior border of the masseter muscle, where we can all feel a notch here on the bone of the mandible. This is the imprint of the artery. You can feel it here. And you can also feel the pulsations. It goes to the alar groove, and during its course, it gives off superior and inferior labial arteries. Can you feel the groove? You clench your teeth, you go like this, you feel the masseter muscle, you put your finger in front of it, you'll find a groove in the bone, you press a little bit, and you can find the pulsations of the artery. You stay away from this area when injecting. And then the angular artery, the facial artery as the angular artery, and here is where anastomosis with branches from the supratrochlear artery. So injecting in this area can cause blindness. That's what they used to say. Nowadays, they consider the whole face as a dangerous area. Because you can inject somewhere down here and it will travel all the way up. Of course, it has a very little percentage of happening, but it can happen.
And there is an anatomical variation.
Yes, there are a lot of anatomical variations. And then see, the frontal branch of the superficial temporal artery, it got two branches, temporal branch and frontal branch. It anastomoses with the supraorbital artery, and here's another point of anastomosis. And people, yes, who have had injection in the hollow temporal areas, a lot of women come and say, these are printed inside, I want to augment them, and then a few days later they can't see anything. Now, what is important here is, here's where the supraorbital and supratrochlear arteries come out from, but they usually pass on the anterior surface of the frontalis muscle. They are on the belly of the muscle, and they want to give perforators down to the muscle and up to the skin. But now that you have got the borders, so medial iris is the lateral border, medial iris is the lateral border, and then you put 2 finger breadths or about 2 centimeters just above the eyebrow. So I got my lateral border here and there, and I got 2 centimeters. This area is the area where I don't know where the arteries are heading. Now I know the arteries above this are above the muscle, but until they pierce the muscle and go upwards, I don't know how they are moving, and I don't care. So the artery can be on bone for those 2 centimeters, then they pierce the muscle and become over the belly of frontalis. They can immediately pierce the muscle as they get out of the foramen, or they can travel obliquely this way. Do I care? I don't care. And if you take a look at people at the gym working out, or people straining, you can always see this. You can see, because the veins follow the arteries, then this is what you see. You see them in the midline, you never see them in this 2 centimeters inferior, because they are compressed underneath the muscle, but you can see them up. That's why if you want to do filler injection for the forehead, then you go deep to the muscle, you touch bone, you glide your cannula over the periosteum, okay? And you know that you are safe underneath the vessels. See? Any cadaveric workshop, see? The vessels are always, those 2 centimeters above the eyebrows, they start piercing the muscle and coming out. So if I'm injecting below the muscle here, I'm in a safe area. Why? Because even if I inject below the muscle and it pushes the vessels against skin, that's no problem. If it pushes the vessels against bone, hard tissue, then you have compression.
Doctor, is safe area above the 2
I'll
fingers.
show it to you. Now, look at the vascular network of, can you see how everything is connected with each other? So all the face is a dangerous area now. Okay. We talked about the superficial and the deep fat compartments, right? Now, if you take off the skin, these are the superficial fat compartments. And you can divide them into, this is the malar fat pad, nasolabial fat pad, which is part of it, jowls, superior, inferior jowls. There are a lot of divisions for it. So you have the nasolabial folds, you have the jowls, which are superior, inferior, you have the medial, you have the middle, and you have the lateral cheeks, you have the lateral orbital, anterior and posterior temporal. But then if you take those superficial fat compartments out, then you have the deep fat compartments around the muscles and nerves, which is deep to the SMAS, you know, the submuscular aponeurotic system, the SMAS. Here's what we lift to do our facelift. The deepest fat compartment is what we call the buccal fat pad. And a lot of young girls would like to do this. They take it out so that they have this chiseled look. She looks like a model, you know, like Bella Hadid. So it's a small incision in front of the second molar tooth. You open a small incision, you find the fat bulging, you take it out, and she's got this chiseled look. And you know, this buccal fat, it extends upwards. This is temporal extension. So all this is buccal fat. When you're doing injections, always mind to look at the patients with or without facial movements, because animation differs. For example, I'm showing you this because of something. Look at that. Look at this area which is sunken. When people smile, this is an actual hologram of someone. See how the muscles move the fats upwards? So a lot of people who inject this area as hollowness, when they smile and everything is lifted upwards, what happens is the cheeks appear as if they are too filled, they are overfilled. So there are certain areas you have to avoid when you look at people doing facial expressions. So if I'm going to see, I see this area is a little bit hollow, I say, okay, I want to inject it. See? But once he smiles, see how it's lifted? So then I have to know how much to put in this area, how to guide my injection so that I don't have overfilling. Okay. So if I get a client like this, okay, if you get a client like this, Dr. Ariba, get a client like this at your office. Sometimes you get ladies at my office saying, I said, what do you want? She said, I don't know. I don't know. You're the doctor. See what's appropriate for me. Now, she's putting me to the test. What do you think I need? Do something nice for me. One time, a client came to my office and said, اعتبرني وش مراتك. Consider me as this is your wife's face. What will you do? So I slapped her. براحتي بقى، ما هي مش هنا، اتكلم براحتي. I can talk as freely as I want. She's not here. I can't say this in front of my wife.
We can do contouring we just tell the patient to smile, and then we will see the movement of the facial muscles, and we can do the contouring.
So I'm a client. I came over to your office. I said, Dr. Ariba, this is my older sister.
Yeah.
Okay? And this is her photo, and she doesn't know what to do, but she wants to look younger. She says, all of a sudden, I think I look old. What do you have in mind? What can I go and tell her? So now I'm her brother, and you're convincing me. So what are you going to tell me? I think we can do so and so and so to your sister.
Yeah, yes. We can do some lifting, contouring of your face.
Lifting, how are you going to do the lifting, doctor?
Lifting with the threads, of course. We
Okay.
can try with the threads.
Okay.
And then we can, like, if she doesn't, usually the patients, they are scared with the threads, so we are trying.
This is the
with
usual.
fillers. Yeah.
This is the usual, even in Egypt. No threads, no threads.
Yeah. So usually
What do
we
you
are-
tell them when they tell you no threads?
I just tell them that threads, it's not that much painful, and it can dissolve.
It can dissolve, it does
It
dissolve.
can dissolve. And it's,
Do you know what's the difference between water and ice?
the solidification, its form is different.
So the form is different, but the material is
Same.
the same. So this is fillers and threads. One is in a gel form, one is in a thread solid form. They both are the same, so what you need is this. If you're gonna put filler, it's the same product, you're gonna put a thread. But one will do the lifting job for you, one will do the filling job for you, and they both dissolve. So it's just like water and ice. Okay. So the options are a lot. See? You can lift her cheeks, like you said. You can also lift her jowls. You know, you can lift her cheeks, jowls, nasolabial folds. You can do the tear trough area. Okay. You can do thread lifting alone and wait and see what will happen. You can do bolus to contour the cheeks, do the marionette lines, nasolabial folds, tear trough area. I mean, the possibilities are endless. But I said, I always go for fillers deeply. I don't go superficial. So this is a workshop in IMCAS in Paris. And remember this photo. Can you see this is a deflated balloon? And this is an inflated one. So an inflated balloon means it has more turgidity. It's strong. So I probably do fillers first to give some collagen and tone for the area. Then I would do thread lifting 2 weeks later, 3 weeks later, because now I'm lifting some solid tissues. Okay. Can you do threads first and then complete some areas with fillers? Yes, you can. You can do both. Both are nice, both are perfect. It's how you get the best results out. يعني ممكن أعمل فيلر قبل أو فيلر بعد الخيوط, no problem. Okay. So I inject to give turgidity or give tension, tensile strength to the tissues. So then when I'm lifting with threads, I get better results. And I can still go for fillers, threads, fillers again. Okay? If there are any small defaults I want to correct, I just go for a minute amount of fillers. And this is a live injection, how we're injecting the tear trough area and how you are piercing what we call the pre-zygomatic space. And Dr. Marwa and I, just the course, the beginner's course, they all took their cannulas and they pierced the pre-zygomatic space and they felt what we call the plop. It's you're going and all of a sudden it just gives weight. There's resistance, and all of a sudden it just goes like this. And you find yourself with your cannula in the infraorbital region treating the tear trough area. It's very simple, it's not scary at all. Just like this. So take off the superficial fat compartments, you're in the deep fat compartments, and your cannula, see where your cannula is? Now you can inject the tear trough area safely. No edema, no vessel occlusion, not to be scared of anything. So this is what you see when you're injecting clients. This is what you don't see because this is what is underneath their skin. And again, see, this is the superficial fat compartments reflected upwards because they become more sagging or more taut, while the deep become more atrophied. That's right. And see, if you want to do a thread lifting, then here's what I lift. We lift the superficial part of it. So you go with your threads, not immediately subdermal, but you go within the superficial fat compartment. So look at this, when you lift, things are lifted upwards. And you stabilize the threads, you fix them to the anchoring points here. Soft music is not matching with the cadavers. I'll put some horror music. And see, you lift and the face is lifted. And this is what you should see. The threads are passing through the superficial fat compartments. This is what you lift. That's why I tend to inject the deep fat compartments first, give volume, give strength. 2-3 weeks later, come, I'll do your thread lifting. Okay?
So for this one, for the deep fat pad, we have to inject with the threads. We have to do the threading.
With what?
For the deep fat pad.
No, never.
Which pad?
These are the deep fat. These are the superficial ones.
So this
Yes.
is-
So if you do You do see, here's the skin, you just take it off. These are the superficial fats. Here's where your thread goes inside. The deeper you go, you're injuring more muscles and nerves and arteries. No, you only lift the, see? So he's lifting now the superficial fat compartments with the threads. These are the deep fat compartments, see? He's reflecting them. All the muscles of the face and arteries and nerves here.
Any type of a thread we can use?
Any safe type of thread, PDO threads, PLLE threads. No, I'm not going to mention brand names, I'm just telling you what they're. Yes. But imagine going inside the needle with a thread and just traversing the facial nerve. What would happen? Facial nerves are deep beneath the smooth muscle, right? That's why sometimes face surgery is very dangerous, because you can have a facial paralysis on one side if you do cut nerves. You do face surgery, right, doctor? You do face surgery.
Just cut, no face.
You do face surgery?
Just
Okay. Filler. Okay. So surgery, I do face surgery. If you're not in the right plane, what happens is you can cut the nerves. So you never go with the needle deep. The needle is always superficial. And that's what I was telling you about now. See, you get people coming in cleaning up this, the hollow temple area. And this is the temporal extension of the buccal fat, which we take out from opposite the second molar tooth, so that you can have a chiseled look. And because people used to inject this whole temple area like this from the temples, this is what happens. This is in a cadaver, see? This is the frontal branch of the superficial temporal artery, and here is where it anastomoses with the supraorbital artery. And this is one connection from the external to the internal carotid artery system. Here's where you can get blindness. Okay? So the deeper you go here, the facial artery branches, facial nerve branches. Here's the facial artery, can you see it? Coming from the masseter muscle. This is the sternomastoid muscle. You know it? Sternomastoid, sternocleidomastoid. Do you know it? There's a nerve here, always passing in front, very superficially, in front of the upper third of the sternomastoid. What is it?
the picture.
What is the nerve passing here superficially? What's the nerve here? It gives sensation to the ear. It's called the great auricular nerve. Great auricular nerve. Anatomy, very important. Okay. So take care injecting this area, and I always tell them a fascia is a tissue covering the muscle. So superficial fascia covers one side of the muscle. This is the muscle, and the deep fascia covers the other part of the muscle, except for this region. It's called the deep temporal fascia, and it's above the muscle. The muscle is so deep that the fascia cannot pass through it or underneath it. So the muscle is actually attached anteriorly here, inferiorly here. There's nowhere, if you're going to inject filler, for it to go, except it will pass superiorly and posteriorly. Okay? So if you take a look, this is the ear, this is the eye. See how the muscle is really attached to the bone. So if you inject in a certain area, the filler can't go here, it can't go here because it's so much tight. The only way it can go is backwards and upwards. So when we inject the whole temple area, there's a technique for that. Okay. Now we've got here what we call temporal fusion line. And we all have this. If you can't feel it from here, there's an easy way to do this. And there is a groove, a longitudinal groove here. And if you can't feel it properly, you go down, and there is a thickening of the bone here, the supralateral, supraorbital, there is a thickening of the bone here. It's like a pillar here, thick. And if you go up with it, you can feel the temporal fusion line. Okay? So can you feel this? And
Yes.
then when you go up, can you feel this line?
Yeah.
See?
Yes.
Oh, and this is the
Yes.
ridge here.
Yes.
Okay? So you go like this. This is called the temporal fusion line. And this temporal fusion line, it separates frontalis muscle anteriorly. And which muscle lies here? Temporalis muscle. usually, when you're doing Botox, you mark the edges of the temporal fusion line to know where the frontalis muscle stops at. In about 20 to 25% of people, frontalis muscle crosses this line. So it's intermingled with temporalis muscle. So if you inject this area and you leave fibers from frontalis muscle uninjected, she comes over 10 days with her eyebrows lifted up so high because you've rested this part and you left this, and you have left or not injected this part. Thus, everything is down except for those which go up because you have missed fibers passing this temporal fusion line. And this is a sign that's called Mephisto sign. Mephisto sign. Okay. So now we've marked the temporal fusion line, and this is zone of adhesion. Frontalis muscle, temporalis muscle, great. So I put my hand and I feel temporal fusion line, I draw it. I go 1 centimeter up or 1 finger breadth, so 1 finger is about 1 centimeter. 1 up, 1 out. Just that easy. 1 up, 1 out. 1 up, 1 out. Again, 1 centimeter out, 1 centimeter up, 1 centimeter outside. So I mark this area and I go, this is up, this is out. So 1 centimeter up, 1 centimeter outside. I stick a needle and I touch bone and I'm injecting, and I'm actually injecting into or underneath temporalis muscle. Okay? So you don't want someone coming from cannula injection in this area with this query, either bruises or venous occlusions or something like this. And if you want to inject underneath the muscle, because I've seen a lot of people, even with fat injection, they inject longitudinally like this. Now, again, it's the same theory. Labral arteries are going like this, you inject across. You want to put a cannula in the vein, you don't put it this way, you put it that way. So you want to inject the forehead, supraorbital and supratrochlear arteries are going like this. So inject across. Okay? And we're going to talk about this right now. Okay. So here's the medial iris. And I feel the notch. Here's supraorbital artery coming out from here. It gives off branches. I tell her to frown. If she can't, I help her with my hand. See the most medial crease? Supratrochlear artery comes out. And this is the frontal branch of the superficial temporal artery. You can all feel the pulsations here. It's pulsating here. Right, so this is temporal fusion line, so now I have marked it. And this is one important thing. Okay. This is a very important structure. So now that I have marked where my supraorbital and supratrochlear arteries are, and I've marked my temporal fusion line, from the supraorbital notch comes out a nerve. It's called the deep branch of the supraorbital nerve. It comes out from here and it passes about 1 centimeter medial to the temporal fusion line. So now I know my anatomy. This is a sensory nerve that gives sensation to the back of the scalp. Okay, it's a sensory nerve giving sensation to the back of the scalp. So now I've put my landmarks. I know where the vessels are, temporal fusion line, deep branch of supraorbital nerve. I've marked the other side, temporal fusion line, deep branch of supraorbital nerve. I put 2 fingers above the eyebrows. I know Those are the 2 centimeters where the vessels are deep. Now they become superficial. Okay? So now, this is the safe area of the forehead to inject. Take your finger. Okay. So this is the safe area to inject. I stay away from the nerve. I stay away from the arteries. So you have all this area to inject. So what I do is now, first of all, I'm going to do the hollow temple area. 1 centimeter up, 1 centimeter outside. You see it? 1 up, 1 outside. And here's my sweet spot. I go in with a needle. Okay. Now, the filler cannot move forward. It cannot move anteriorly here. The only way it can move, because the muscle is so much attached to the bone, it will either move backwards or inwards. So I put my finger backwards. Now the only area the filler can go now, because I'm preventing it with my finger, is it's going to go downwards. So it's going to fill the hollow temple area. So if you want to inject this area, this is how you do. Field of temporal fusion line, 1 centimeter up, 1 outside, stick a needle until you touch bone. If you're going to inject the other side, change the needle because it becomes so dull. So you put it to the bone, and you start injecting slowly, and you have your finger behind, so the filler will come and it will fill this area. You aspirate, you count to 10, and then start injecting. I have my finger here, so it's not going to go anywhere except fill this area. And this is the safest way to do it. I stopped using cannulas. I stopped injecting this area with anything of that sort.
27 gauge.
Huh?
27 gauge.
I don't care what gauge you use. Just a simple question. So if you use 30 gauge, 25 gauge, 20 gauge, this doesn't change the principles you're working with. Okay? If you go on like this, I don't care what gauge you use. So, what if you are at a hospital and there are no 27 gauge? What will you do? See, that's what I'm talking about. Don't try to memorize numbers for surgery or for medicine. You know, everyone is trying to put it inside a frame. How many gauge? What's the gauge of this? I don't care what gauge you use. If you are planning it anatomically correct, so I marked my lines, it's just going to be a little bit more painful with the client, right? But by the way, the bigger the gauge, the less probability you are going to be inside a small vessel. So bigger gauges are safer. Okay? So I just follow rules. I know where I'm going to inject. I never look at the gauge size. 25, 26, 27, 29, 30, 31 gauge, I don't care. Because I have done my homework correctly. I know my anatomy, I know where I'm injecting, I don't look at the gauge size. Okay, so now I'm injecting anesthesia, supraorbital and supratrochlear areas, and I'm injecting along the deep branch of the supraorbital nerve. Then I will put my trocar beyond the nerve, so I'm away from the nerve now, no sensory pain, and I'm going to stick my cannula, and I'm going to put it deep, deep until I'm gliding it over bone. See, I'm hitting bone. Now I know I'm underneath the muscle. Not only am I underneath the muscle, I'm also injecting across. So it's much safer than injecting longitudinally and becoming inside the vessel. And I also under-inject and add more if I need. Nasolabial folds, there are several ways to do it. I've got 2 preferred ways. One is injecting it across from an entry point over the cheek, or you can just go perpendicularly with a cannula, which is safer than a needle here. Go over bone and touch the piriform fossa. This is a bony part. and this is the area I inject. So I put my finger, I limit where the filler is going, and I inject the pyriform fossa until it's developed. So injected the hollow temple areas, raised her eyebrows, her forehead, her nasolabial folds. You give her a few days, and she comes looking like this. See how her eyebrows change? If she's happy that way, it's okay. If she needs more, well, why don't we do more? Now this is from the Harley Academy. You can still see another way of injecting. It's the same thing.
Gently open your jaw.
So,
This relaxes the temporalis muscle. Sharp stretch.
1 centimeter up, 1 centimeter out, deep to the bone.
Perfect.
See?
Touching down on bone.
Hold the needle,
Aspirate.
aspirate, count to 10. If there's no blood coming out,
And then all of
start
this
injecting.
is going into the temple. Now, it can't flow upwards. It can't flow forwards. The only way it can flow is backwards into the hairline. So I'm putting some pressure
See,
with my
you put
thumb
your finger backwards
just
here,
to
it
usher
can't go
the
this
filler
way, it can't go
into
that
my
way.
body.
It will only go backwards this way. Once you put your finger here, then it only has to go down and fill the hollow temple area. And this is the safest way to inject
So what I find here,
temple
Mark, is
areas.
this patient the next day feels a bit of tightness in this muscle when they yawn or when they stretch their face. It's because the muscle itself is being stretched. This muscle adheres very tightly down on bone, and you cannot get filler underneath muscle here. The filler is technically sitting in the inferior fibers of the temporalis muscle.
See? Very slow injection. Very slow injection.
1 point.
Huh?
1 point.
Now you're putting the whole ml here. Where is it going? It's all going in this area. You don't have to put the whole ml, you know, put a, and take a look and assess. Maybe half an ml is sufficient. Maybe another person needs 2 ml.
Don't need massage,
Of
right?
course you need massage. You have to.
And then we'll have a bit of.
And you
So
start
again,
seeing.
I'm just going to usher that down into the temple fossa. Now, if you can sit forward.
And you can
forwards,
even see her
once
eyebrows
it
will be
stays,
lifted a little bit
eyebrows.
with this technique. Temporal area, when it's inflated, it takes the lateral part of the eyebrow upwards.
Excuse me, some patients don't like this hollow, not temporal.
Some people don't want.
Complain that this is concave.
Yes.
We can't inject it here or here, not row.
No. Now, what he did when he injected here and he pushed the filler downwards, this is to treat the area you're talking about. People who come and say this area is hollow, is empty, is concave, and this is how to treat it.
Oh, and this is above than here.
The whole area.
Whole area. This one is above the here.
عندك wait. He's your husband?
Yes.
So I'll sacrifice him for you. You can do something for your wife, right? So this is empty. Now here is the bone, right?
Yes.
Then sacrifice him. Okay. It's erased. So the filler, you feel the bone,
Yes.
okay?
Okay.
So now this is the lower part. This is the lower limit. So it can't go beyond here. This is the area we need to inject, right? This hollow area, hollow temple area, right?
Yes.
Okay. So this is temporal fusion line. This is the ridge,
Okay.
and you go upwards and you can feel the line, right? Here it is, here it is. Okay, so you mark it. Now, 1 centimeter up, so it's like this. 1 centimeter out. Just do this. Up and out. See? It's this. From your last عقلة اللي اسمها ايه؟ last pull up عقلة.
Okay, this one. It's
From-
different.
for the distant
One
phalanx.
tail
Just
down.
right. So you go like this. So 1 up, 1 out. See, 1 up, 1 out. So 1 centimeter up, 1 centimeter outside. Just the sweet spot. So what do?
This is lifted.
You put your needle,
Okay.
tuck, touch bone, start injecting, and when you inject, have your hands like this.
So we
It
try
can't
to
go
flat.
here. It can't go down.
Drill hand.
It can only go backwards.
Okay.
So now I put my finger here and I'm injecting. This is all filling, all filling. All you do after you finish, you just push it here, see?
Uh-huh.
And it fills the whole area.
I understand.
You don't need to do anything else.
Okay.
Okay?
So where is the superficial temporal? Can you just make the marking for superficial temporal?
No, I'm.
Your wife better.
Where is the superficial temporal?
Huh?
Dr. Ahmed, where is the superficial temporal? Can you mark?
Can you mark the arteries on his
No.
face?
You cannot mark it?
You come and check. Ask her to.
Permission.
What?
Try it on me. Try it on me. Try it on me. Try it on me.
Yeah, yes, superficial.
Try it on me. Where's the superficial temporal?
You
We
don't
can feel the pulsation.
goes from that side, it goes like that. And
How
it
can you
lasts
tell me?
goes-
How can you tell me mark the point when you know there are so many anatomical variations?
Yeah.
So feel my superficial temporal artery. Where is it? Can you feel it?
No.
Try to feel it. Come on, try to feel it.
It's here.
Thank you very much. Right, so it passes like this. Now, supposing my superficial temporal artery was here, supposing. So you get your needle and you stick and you go deep down to the bone. Once you're in the bone, even if you pass with the needle through the artery, you're not in the artery because now you've pierced it and you've passed the other side. Now you're touching bone, see? So I've passed the vessel, I'm touching bone. What happens is you're going to inject, it's going to be underneath the artery. The only thing is, when you take the needle out, it starts to bleed. So then you compress. Now, as long as the needle is inside, the artery is not going to bleed, right? What's this called? You know, like, no, like, I've had once in the emergency, a wife stabbed her husband, not you. Okay? She got a knife and she stabbed him in the heart.
Don't
Okay.
push out. Don't.
You don't take it out, because if you take it out,
She
it
does.
starts to bleed. As long as it's inside, there's no bleeding. It's the same thing. So you pass with your needle through the artery, it's not going to bleed. Once you take it out, it starts to bleed, then you compress and that's it. Nothing. But you're not injecting in the artery because you've actually passed, even if you do, you're touching bone. So you've passed the artery. So what is this effect called? When the needle is inside the artery, it's no longer bleeding until you take it out. Just like stab in the heart.
Stab.
It's called what? Basic medicine. Huh? Have you heard of the tamponade effect? It's called the tamponade effect. Yo, من أيام ستي It's called the tamponade. Now, I used to see people who injected the whole temporal area like this. Look, they come with a cannula. They can come from the anterior hairline. They can come from the tail of the eyebrow. They can come from this part. What happens is you're superficial. See, to avoid any of the vessels, you have to be superficial. Otherwise, you're going to be immediately inside the vessels. See how close the vessel is. So, if you inject this way, you're going to be superficial. And then you either use something with a low G prime, otherwise it will cause a lot of bumps and lumps here, right? Or you can be inside, see how thin it is. You're going to be inside the muscle, you're going to be inside the vessels. So a safer way, draw yours, put your needle deep to the bone and start aspirate. Count to 10 and start injecting slowly. Keep your fingers behind, and the filler will settle down and fill this area. You just push it down like this.
Doctor, this question. When I touch the bone,
Yes.
I just put the filler on the bone or يعني أسحبها شوية كده
No.
on the bone.
Once you've reached the bone, and I tell you that if you're going to change the other side, you change the needle من كتر ما انت بتدوسي على العضلة. Don't take it out. If you take it out, you are in a different plane. You know, in such an area which is already very thin,
Yes.
1 millimeter can mean the difference between you inside or outside of us. So once you're touching bone, you're touching bone. You keep it that way. Okay? So now injecting, this is another area where I use needles and I go deep to the bone. If you're injecting the angle of the mandible, you know there's the ascending ramus, there's the descending ramus, the body of the mandible. So this is the angle between the descending ramus and the body. Okay? So it's this part, which a lot of people like to augment because it gives a good look.
What I'm going to do here
So
is find
what you
the
do
corner of
is
the
you
jaw
hold it in your hand like this,
and I'm going to create a sharp scratch. 1, 2, 3.
you go inside,
Down onto the corner.
you have to be over touching bone.
Here.
Right?
the mandible.
So if you are passing the masseter
Here,
muscle,
do an aspirate.
even if you are passing parotid gland, once you are touching bone, then you have passed all these structures.
As I go,
Then who cares? You take it a little bit backwards, then you're injecting in the parotid gland. Touch bone, keep it on bone and inject. Nice. Okay? And again, this is in this area. See, here the fat layer is are thin, and you can be just over muscles. So people who do jawline contouring, right? So you can either be with a needle deep to the bone, just avoiding this area where the facial artery is, but otherwise you can be deep to the bone except in this area, or you can be superficial here to do contouring. Right? This is a safe area. You're just beneath the superficial fat compartments, and supposing filler migration happens. I wanted to settle down here. It will give me the jawline contour. So it's not going to go down here in the neck. It's going to stay here because these fibrous bands are holding it in place. See? So you're injecting this. See, this is a live and this is a cadaveric injection. See? It's fixed here. What is fixing that? It's platysma muscle. So any filler you do will stay in this area and help you do a contouring. Or you can go with a needle, deep, touch bone, put boluses, mold them together. Just stay away from the area where the facial artery is, or you're in deep trouble. So I mark this area, I inject in front of it, I inject behind it, that's no problem. Over bone.
There's no notch.
There's not a notch, there's what we call an imprint, طبعا. Feel it.
Yeah, I feel it. أقصد الفيلر.
ماله؟
إذا حطينا deep في anterior and posterior to the notch of the facial artery, the area of the notch will be deep, right? Will still يعني بيكون في زي نص كده مش عارفة اشرح، بيكون في زي قطعة.
So the area of entry is in front of the notch where the facial artery is coming out.
Clench your teeth. ريح. You have to pay each one 5 dirhams for Dr. Inas to touch her.
No, your face, just here.
Not touch your face or not to pay?
pain.
Okay, so she's gonna clench her teeth. You can feel the
Feel the
anterior
masseter.
border of the masseter. Just in front of the anterior border of the masseter.
The notch we can
And,
feel.
and listen, I want you to do this because all women do this. Yeah, when they feel something. Just put your hand and slide it gently across. So I felt the muscle, then I slide it until I find the notch here. Look, here there's a notch. Now if you go press a little bit, you can just gently, gently. You can feel the facial artery pulsation.
So what should be the landmarks
Can you
of this?
clench your teeth?
Now relax. Did you feel the pulsations?
No.
You have to feel them against bone, not against soft tissue.
Yeah.
We can inject it here superficially, yes?
Sorry,
لا
dear.
لا خلينا كمان.
You're right.
So I clench my teeth. This is masseter muscle.
Yes.
Masseter muscle, okay?
Yes.
Now, there's a notch here. And if you press, you can feel the facial artery.
Yes. 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 Yeah.
Here it is.
Yeah, I don't
Can you feel the pulsations?
a little thing. Ah, yes.
Press gently.
Yes. 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 Thank you.
We should
So you
be
never,
put the-
you never inject deep here.
See, for the jawline, we should be put the
أهلا أهلا أهلا.
I can do exercise.
So هدوس على سناني هتحس ان مسرة المصر حاجة قدامها في حتة طبعا في العظمة هي شايفاها؟ ده مطرح ما الفيشال ارتري عامل طبعة على العظم فرنت. حس البلسيشنز. بعد عن الحتة دي.
The point of injection is going to be a little
Yeah.
Anterior
front
or posterior, just stay away from that part.
طيب يا دكتور مش هتبقى هي depressed يعني لو احنا عملنا anterior posterior الحتة دي مش هتبقى depressed ولا مش باينة.
حتة ايدي بريست. احنا خدنا بريك من شوية. طيب 10 دقايق. And you can introduce your cannula from whichever direction you want.
For a negative.
As long as I know my landmarks. So I stay away from the facial artery. I stay away from the angular artery. I stay away from the superficial temporal. I stay away from this and that.
Array treatment on the screen.
Then do whatever
Making
you
sure I
want.
don't make any mistakes. Brilliant. Thank you. Yes, of course, please. Thank you. And what I'd like to do here is
And then you
just
start massaging. You have
a
to
bit of
distribute
massaging
the
to make
fillers
sure it's
equally.
continuous jawline.
The chin, I use a needle or a cannula, both, and I go deep and I touch bone. See, you're touching, this is what you see in real life. This is what you get in a cadaver. So see, I'm touching bone here as well. So I'm avoiding everything necessary. So I inject, take off this, see? nothing to be afraid of. You just inject over the bone and it bunges everything forward and it gives you a good definition. This is not so important. Sometimes people don't like this fold underneath the lip. This is where mentalis muscle is inserted. So you might try first of all putting some Botox here to relax the muscle. Then you can do this. But never inject up here. Because here is, if you're going to affect the depressor, the depressor labii inferioris, you're going to be in deep trouble.
I'm actually battling against them a little, and now I've got halfway across. I'm going to start to inject. Now we're just going to be able to gently fan in products, because Volux has got such good elasticity. It's all we need to soften this. We sometimes teach in our training that using the codes, this will be C1.
So this is layer 2. So we're literally just through the so we're layer 2 at this point. So you've got to see the outline of the code. The patient is very, very good at it. Yeah. It can be a bit tough and aren't it? Painful for that. I think for me, this crease is one of those areas that people don't. No one comes into it and says, well, you know what I really want doing today? This crease. But it's one of those areas when you.
Marionette lines, you can mark them and do them like this. You will also be underneath the superficial fat compartments, you see? And you're going to lift a little bit of the depressor anguloris muscles. You can enter and inject it this way, you can enter and inject it that way. I don't care what you do. This is all the superficial fat compartments. Malar fat pad, it has to be in place. Right, so So this is intradermal injection of fillers along the nasolabial folds. You're in direction of facial artery. This is how I used to inject about 25 years ago, and I stopped doing this. And
What's the strength of that 25? 15? So Logi Prime?
what?
Logi Prime that you are doing intradermal?
That's not me doing it. I'm just giving you demonstration videos.
Okay,
So everything that has something appropriate for the, see, don't even try to fix a certain filler for all nasolabial folds, because some people have really deep and heavy nasolabial folds, others have a very thin line. You can't say, right, I'll use this for nasolabial folds in each and every one. I'll use this for lip in each and every one. I'll use this for cheeks. It's how you can assess what filler you need and how much amount you're going to inject. Again, you're trying to memorize something to go on with. It's like putting medicine in a frame. Don't do this. Okay? Don't mind about the gauges of the cannula. Don't mind about the filler, because sometimes I put, for instance, volume. I put volume in the nasolabial folds. While I have another, from the same company, another box called deep wrinkles. But I'd use volume. Why? Because they have very deep lines. I put volume here. And I put deep lines in the lips sometimes. I do everything I need. As long as I'm working on basis of anatomy and knowledge. Right? How much I will inject, where to inject, under inject and follow up later. So never mind what filler you're going to use. Sometimes I used volume for nasolabial folds. Sometimes I used deep wrinkles for tear trough areas. Sometimes I don't use moderate fillers like those for the lips, and I use something that's really heavy for the lips. It's how I see you have thin skin or thick skin, how you have deep folds or heavy folds, right? So if you are going to try to memorize one thing for everything, it's going to be a lot of things to memorize. And this is, see, when I tell you I go to the pyriform fossa deep to the bone, this is what happens sometimes when you inject superficially. You have to take care of this. So when you divide those buccal fat compartments, you start dissecting the pyriform fossa. You want to go deep in as much as possible, touch bone, then I'm away from everything. And look at this. See how see how superficial, how close the facial artery is, and it's starting to divide into the angular artery and dorsal nasal artery. So avoiding injecting within the soft tissue, because I don't know where the vessel is. Just go deep inside until you reach bone. And even if you do puncture the artery, it's the tamponade effect that I've told you about. In men, we used to do this. Now a cannula, you can't be intradermal with a cannula. You have to be subdermal or subcutaneous. ينفعش ابقى جوه الجلد بكانيولا because cannula has a blunt tip. It's not sharp. So you cannot be in the skin. You are underneath the skin. So now this is linear threading. Okay? So he's injecting the whole area. Trocar side, cannula goes back inside. So this is linear threading. And this is why I tell you it's dangerous, because facial artery runs like this. Nowadays, I put my cannula here and I inject the nasolabial folds across.
Mesh.
No, it's not a mesh. Mesh, if I go like this and this, I just go across. Because the facial artery is like this, I go from here and I inject it either like this transversely, or I go inside deep to the bone and I inject the pyriform fossa. There you go. Then because he has very deep lines and he's building base, then he goes superficial with a needle to be inside the skin. And what is he doing with the cannula? He's doing like a subcision. He's cutting off the pipe. Now you go with the thin cannula with the needle intradermally. Now this is cross-hatching, see, he's going across. When you have enough experience, you will not aspirate. Because you are going to be looking for other things. Okay. Now this is what we call the high-risk injection, filler areas. This is one of the entry points, very, very famous in common, above the zygomatic bone. And you see, when he's doing this, he has to be superficial. Then you get bumps and lumps here. See, it's not even. And it's very dangerous. You can be inside the superficial temporal artery. This is the safest way. Temporal fusion line, 1 centimeter up, 1 out. Put your needle and inject. Now, passing the this is the temporal fusion line, passing what we call the deep branch of supraorbital nerve, then you inject the forehead across. Now this is a different entry point. You can do definition of the jawline. Now, can you go deep in this area? Yes. Then what do? You end up injecting where?
Here, this
Yeah.
area,
This is it. Can you go deep here?
Yes, all this
No, you
area.
can't. No, you can't. It's only over the angle of the mandible to the bone. Otherwise, if you're deep in here, where are you going to be injecting? Parotid gland. You can't be deep in this area. This is one of the areas where you are superficial. If you are deep, you're inside the parotid gland. See, just to do contouring, see, you can see the cannula moving. It's superficial. If you want to be deep, go perpendicular with the needle and inject boluses all the way, move them, and stay away from this area.
دكتور مرات السوبرفيشن هنا بتكون ثابتة لما تتحرك المعدنة، بتكون الفيلر ثابت هنا
قلت لكم عليها دي
أيوة في الهواء.
دايناميك. اوكي. كده شغال احسن من هو It's the same. Okay. Now, let me show you something that might help you. Just might help you. Yeah, Dr. Ariba, leave the mobile now. We're about to be done. Do you have to go? I can speed things up.
It's okay.
Right. So, you touch your zygoma, upper border, lower border. You mark 2 points. Then you go downwards to the nasolabial folds. Upper part, lower part. Okay? Then you start to connect those 2 lines together. Now, from the most prominent part that you can see with your eyes, this is the most projecting part, you draw a line downwards. Then you put your finger along the nasolabial fold and you go 1 centimeter above, that's it. You draw your second line. Okay. Now you have 3 different zones. 1, 2, and 3. If you start 1 from here and 3 here, 2 will always stay the same. Okay. So no matter if you start say 1, 2, 3 or 1, 2, 3, 2 is the same, and this is my main focus point. So when you want to push the malar fat pad again, see, so now I've drawn where the zygoma is, upper part of nasolabial folds, lower part. This is the most prominent part I can see. This is the most projecting part I can see. And I draw a line downwards. And then I put a finger, 1 finger breadth, and here's where I put my other line, okay? Now this is zone 1, 2, and 3, or 1, 2, and 3. So zone 2 is of my interest, okay? Now look at what happens because the malar fat pad descends downwards and medially. When you push the malar fat pad, what happens? Look at zone 2. Can you see what happens? So this is the main area you need to inject in order to get a picture that looks much more youthful and with less nasolabial folds prominent. So for me, there are 6 areas I do. The forehead, I go to the bone. The cheeks, I go to the bone. The chin, I go to the bone. The nose, I go to the bone. The pyriform fossa, I go to the bone. And the angle of the mandible, or the angle of the jawline, I go to the bone. Infection or superficial or expired fillers will get you a granuloma. Come presenting like this and you have to take it out, or a granuloma in the face. Granuloma in lips is even worse. Tear trough area, be careful from the bruising, Tyndall effect. We've talked about that. Granulomas with repeated infection can cause a picture like this. Okay. Now, you know what you can do with 2 ml fillers? You can do something like that. You can inject the jawline, make a good contour, just area beneath the marionette lines here, a little bit on the chin, angle of the mandible. Same thing here. Here I did fillers, then 2 weeks later I did thread lifting. I did thread lifting here, then I did some fillers later on. This time she was doing some fillers in her face after threads. That's 3 ml of fillers, whole face. 2 ml of fillers. Just 2 ml of fillers, whole face. Forget about this. Now sometimes, like I said, the injection cannula, I don't have to use for injecting only, I can use for sculpting the fats of the face. So here, I sculpted the double chin. I've injected in the jaw, in the angle of the mandible, the chin, but I've sculpted fats in the double chin area. So now she looks much better in a side view. Now after you suck these fats out, put a little bit of contouring here, a little bit of contouring in the chin. Look at that, see? And I also did her jowl fats. So I've taken these off, and I've taken this off. I did at the same time fillers, threads, and Botox for this lady. I did thread lifting for the cheeks. I did a little bit of fillers in the chin and the lips, right? And I did the jawline, and I did her Botox up, all in one session. And remember, if you're going to do any, like you say, Texas, any jawline contouring, please make sure that they don't have sagging skin like this. She's not eligible for injection. She needs a surgery. Okay? So you mark the points, and always assess it with the cheeks and with the chin. Right? So in order to get a definition, so always assess this. You don't want to have a prominent jawline and a flat cheek, or the opposite. So you can do both at the same time. And that's what I mean. See? Sometimes, because she's younger, you don't have to do liposuction of the double chin. Just putting enough fillers here and the jawline and a little bit in the cheeks, because she has a good tone of her skin, you get this. Remember this young lady I showed you at the beginning? We said we changed the background. So, again, sometimes it's not only lifting, it's not only injecting. Sometimes you can take away, you subtract, not add. So I did liposuction of this area of the jowls, and I put some fat injection in the chin. Okay? And she was nice, and she came 1 year later and said, no, I'm not happy, because I've been talking to Dr. Malik Koti of California. And we agree, we were talking about discussing the 6 points facial contouring versus the 7 points facial definition I do. And I started to do this where I do suction of several areas. So you can actually use your cannula and do liposuction in these areas. It's going to be very easy. So anyway, so she came back. This was her 5 months later. Then she came back, and about a year later she said, okay, I look like this now. Everything is settled. Edema is better, but I still don't like the way I look. I want to look much better. And then I didn't do any injection. Actually, I did some taking. I didn't add, I subtracted. I took away from. So just sculpting her face. So a year later, I go in, I do her 7 points facial definition, and then that's what she looks like now. She did something with her teeth as well. You get people in a much better psychological form. Now, lip enhancement, the same thing. Like I said, there are several ways to inject the lips, and we're going to talk about those dangers. But this is one of the worst things that people are always scared of, the tear trough area. So this is how some people do it. They go deep with the needle, they inject micro boluses and they are just underneath the superficial fat compartment. I'm telling you, this is exactly what happens with, see? This is the tear trough area, and then you're injecting just below the skin, just below the superficial fat compartment. And this is where you get bruising, and this is where you get the tendons effect. If you want to do this, there's a certain entry point that I'm going to tell you about now, and it is mainly draw a line from the angle of the eye, lateral orbital or lateral canthus downwards, and then one that crosses from the ala to the upper tragus. Or there's something else. This is the lateral part of your eye. Start going downwards, you're feeling bone, and then now there's no bone. Why? Here's where my teeth are. So I want to stay over bone. Okay? I want to come at the most lower part, if I have enough space, lower part where I can feel bone, after which there's no bone. And here's usually my entry point. And I can go inject this area to do contouring. I can inject this area to lift the cheeks, tear trough area, everything. So it's usually from the lateral canthus where you can feel bone. Go down with your cannula, deep touch the bone, then glide your cannula over the periosteum. You can be inside the tear trough area after pacing the prezygomatic space with no fear of anything. Take a look at this. Is she superficial or deep?
Superficial.
And I'm showing you how a lot of people do these things. So, sorry, the first one, it was superficial.
Deep.
Superficial, no, she's not superficial. She's not deep. Look where the needle is. You're supposed to be deep to the periosteum. The first one is deep to the periosteum. And you put microbull, see, deep to the periosteum. Now this is a little bit superficial. But you should be over the periosteum. Now with a cannula, I go deep to the periosteum, and I also pierce the prezygomatic space. And when I'm injecting here, it's very simple. Now in the previous one, she was almost lying down. When you're treating tear trough area, it's always better to have her sitting upright like this. تبقى قاعدة. Huh? She has to be sitting up like this. You will judge it much better.
We should not go deep, and we should not.
I go deep.
Yeah.
I go deep.
Because we are usually going deep, and there is a sound, popping sound, and when we are going.
That's what I'm telling you. The flop. It's all of a sudden, and then you're pacing the fascia, prezygomatic fascia, and then, like I showed you in the cadaver, the first one was deep under, just over the periosteum, the deep compartments. That's what you should do. This. And now the problem with blindness that happened a long time ago. The problem with blindness that happened a long time ago was, this is how Koreans, especially Koreans, would inject the nose. They would go from the tip here between both columelli to the soft part here. So they go inside with the cannula all the way longitudinally up to inject and try to enhance or treat nasal humps. So they go like this and they inject all the way up like that, okay? And then they would turn the direction of the cannula from this same entry point. They go up like this, then they go back deep down inside here where there's the foot plates, They touch bone over anterior nasal spine and they inject, so they raise the tip upwards. Now the problem is, if you're not exactly in the midline and you're deviated just a little bit, you can completely go with your cannula inside the artery. And then you start injecting, and then she's blind in a few hours. So, see, you can be inside a vessel without even knowing it. And you can be outside some part, but when you come back again, you'll be injecting some part of it. That's why when you want to inject fillers in the nose, you use a needle over the bone, in the midline, and perpendicularly. So you go like this, one bolus here, until you treat the nasal hump. Stop doing cannulas that way, just perpendicular in the midline, touch bone with your needle, you feel it inside the bone, aspirate, inject slowly, and when you are injecting, put fingers like this to contain the filler from spreading laterally. So it's just confined to the dorsum of the nose. Or start doing threads. So this is the entry point they use for fillers and for threads. So you go inside like this, you lift the tip as much as you can. Or if you are going to inject, if you're going to inject the nose, perpendicular in the midline, and just inject very slowly. See, put your fingers, contain the filler in the midline, inject small amounts to treat again. So if you want to do threads, which are much safer, do threads for the nose. Lift the tip and treat the dorsum. Or perpendicularly inject fillers like this. Always aspirating, counting to 10, slowly injecting perpendicularly over the nose and the nasal bone, just to treat the hump. And you get a picture that looks like this. You can, by the way, you can use both. You can do threads and you can do fillers. You can lift it and you can treat. Okay? This is all non-surgery. You can use fillers for the dorsum of the hand, and you can use fillers for body fillers. Some small things like this. People who have a cut ear lobule, and then they go and suture it at a surgeon. Sometimes if the surgeon doesn't sew this back in place properly, you get a print like this. And you can inject it to enhance it. Do you think you're going to inject here with a high or a low G prime?
Low G.
This is a very thin, delicate area. You don't need a high G prime here. Here is where you inject a low G prime.
So one more question.
Sure.
One of our fellow doctors wanted to get a filler done in her earlobe because she said it's hanging. So again, we can just inject randomly with a low G prime.
What do you mean hanging?
She says because the fat is lost, so it's a little loose and hanging. She's a little old, so she just wanted her earlobe to be fixed with a filler.
You go very superficially with a needle that's not more than 3 millimeters long, like mesotherapy, you know, and just some points in it to give the lobule some strength.
Would it be better with something like a polycaprolactone? That might.
Polycaprolactone. This is a very high. This is what we call because PCL, polycaprolactone, is usually associated with PLL8s like Sculptra and Elancey. This is for really heavy stuff. Now, those of you who have asked me for any contacts, if you want to ask me any questions at any time, if you want to send me you want to ask about anything, you want to take my opinion, anything, be just in contact. Just.
And what about Profilo?
What about it?
I mean, like, this is one of the fillers that says that we do collagen enhancement and stuff like that.